Welcome to AETCM, the emergency medicine channel. Shall I start, sir?
Yes.
Presenting the case of a 56-year-old male who is actually known case of chronic liver disease, who came to ER with complaints of diffuse abdominal pain and fever since the last 2 days. So on initial 10-second assessment, the patient was conscious oriented. He was talking in full complete sentences. The airway was patent. There was no pooling of secretions or gurgling sounds or stridor. And breathing wise, the respiratory rate was 18 per minute with a saturation of 96% in room air. And the chest wise, the air was bilaterally equal and there was no presence of any added sounds. And circulation wise, the BP was 90/60 millimeters of mercury with a pulse rate of 86 beats per minute and a capillary refill time less than 3 seconds. And disability wise, the GCS was E4, V5, M6. Pupils were equal and reactive to light of 2 mm size. And exposure wise, there was no presence of any additional any rashes around the body. And GRBS was 70 milligram per deciliter. And the temperature was 100 degree Fahrenheit, 100.1 degree Fahrenheit.
Okay.
So initially the patient had a temperature, fever spike. So we had initiated injection paracetamol, 1 gram IV stat dose was given. Following which we had gone to an adjunct to the primary survey. We had also taken a CBCRP point of care, which was showing a total count of 15,000. Yeah, with an HB of 9 and a platelet count of 96,000 and a CRP of 112.
CRP of 112.
Yeah. And venous blood gas was also taken for this patient, which shows no features of any acidosis or alkalosis, with HB of 9.2 and a potassium of 4, sodium of 126, creatinine of 1.2.
1.2.
Yeah, and lactate of 2.
Lactates 2.
Yeah. So we had also further taken the sample history of this patient, and the patient was a 56-year-old male, non-case of chronic liver disease with portal hypertension. So he had actually complained of diffuse abdominal pain and fever since last 2 days. So he is not giving any history of any vomiting, loose stools. He is not giving any history of any we also asked the bystanders about the history. They did not give any history of any altered sensorium in this patient. And there is no history of any hematemesis or melena in the black colored stools or blood in vomitus was not found in this patient. And there is no history of any previous admissions for the same complaints of UJ bleed. And there is no history of any recent alcohol intake or red meat intake. And there is no history of any cough or breathlessness in this patient. No history of any dysuria or reduced urine output in this patient.
Okay.
So we also asked him the allergic history. He is not allergic to any drugs. The medication history he is on Udiliv and is also on Carvedilol. So in the past history, the patient is actually known case of chronic liver disease with portal hypertension. The last meal was taken 2 hours back. Following which we had done the systemic examination. In this patient, the patient was conscious oriented. There was no presence of any flaps in this patient. And on per abdomen, the abdomen was soft but distended. Along with the patient had diffuse abdominal tenderness. Okay. But we did the shifting dullness was positive. But there was no presence of any rebound tenderness as such. And the bowel sounds were heard, and it was bowel sounds were normal. And the CVS wise, the cardiovascular system, the SO2 was normal. There was no presence of any murmurs.
He's also been passing stools, flatus and all.
Yeah, he has been passing stools. There's no history of any loose stools either, no history of melena also. And then CNS wise, the patient powers were also normal. There was planters were also flexors. And then following which we came to a provisional diagnosis that the patient has come, it's a known case of chronic liver disease. So he has come with complaints of basically diffuse abdominal pain, mild abdominal distension and fever since the last 2 days. So with no other sources of infection which we could find out through the history. So we came to a provisional diagnosis. He could be having a bacterial peritonitis. Spontaneous bacterial peritonitis is what we came to a provisional diagnosis. And the patient, then we had, by the USG guidance, we had done an ascitic tapping for this patient. And by the tapping, we had got the result for the same as the patient had ascitic fluid total count cells of 620 with the neutrophils of 400 cells per millimeter square. And
microliter.
Yeah, per microliter. And the protein was found to be 1.5 gram per deciliter.
Okay.
And the serum albumin was also taken through the labs. It was 3.2. So
3.2.
Yeah, so the SAG gradient was 1.7 more than 1.1. So it was found to be a translated.
It is found to be portal hypertension.
Portal hypertension associated. Yeah. And glucose was 60 milligram per deciliter. And the LDH and amylase of fluorescent, it was low.
Low.
And so we came to a final conclusion that the patient could be having spontaneous bacterial peritonitis.
All right. So we have a 56-year-old male patient who is a case of cirrhosis, decompensated liver disease with ascites, who's on regular medications and well controlled, who's presented with complaints of fever, abdominal pain, and abdominal pain.
Yeah.
So this patient, if I'm not wrong, the patient had a BP of 90 by 60 millimeters of mercury, but the heart rate was also on the lower side, for which you already have an answer. He's on carvedilol for that. So when we go to the discussion of spontaneous bacterial peritonitis, we should know about how ascitic fluid is formed, which we have discussed in our previous videos as well. But to just brush it up, basically the ascitic fluid is formed on a regular basis in the peritoneum. Around 30 to 50 ml is being produced continuously. So when does it becomes clinically significant? When the production exceeds the drainage. So this 30 to 50 ml is being effectively drained by the portal and the diaphragmatic lymphatics very efficiently. But we know that the ascitic fluid production is mainly guided by the Starling's law, hydrostatic pressure, oncotic pressure. So whenever there is some change in that, there is increase in hydrostatic pressure or because of portal hypertension or any fluid, intravascular fluid retention. And also at the same time when there is decreased plasma oncotic pressure, which is mainly contributed by albumin in this patient, especially when in liver disease albumin concentration is going to be low. And also at the same time due to some pathology which would lead to lymphatic overwhelming of the lymphatic channels, and there is lymphatic leak, and at the same time there is some amount of capillary leak. All this would lead to ascites. So the current theory of ascitic fluid formation is that there are basically a couple of hits that happen. The first hit would be a cirrhotic liver, which is in the fibrotic phase. What happens? There is increased elevated portal pressure, which is radiated back to the splanchnic circulation. There is splanchnic pressure is increasing, eventually leads to vasodilatation. Splanchnic pressure is more, and because of which the effective arterial blood volume decreases, because your splanchnic circulation is getting a lot of blood supply which it is not earlier getting. So the kidney would recognize it as a decrease in effective arterial blood volume, and the renin-angiotensin aldosterone system is activated. The end product of which, what happens? Sodium and water retention is there. So ultimately there is increase in hydrostatic pressure because of all these components. And also at the same time, cirrhosis by itself is a pro-inflammatory condition. So there will be at some point or the other, there will be some point of capillary leak as well. And also the lymphatic channels, also because of the extensive increased portal pressure, there will be leak from them that as well, which leads to ascites. So that is how ascites is happening. Right. Now about spontaneous bacterial peritonitis. Spontaneous bacterial peritonitis can be defined as the infection of the ascitic fluid without any other evidence of other obvious signs of infection. What are the other obvious signs of infection or peritonitis? One is when perforation of holoviscus happens, perforation of gallbladder happens, or if there is any UTI, as you said, you clearly ruled it out with the history. Whether there is rebound tenderness is not very specific for it, but I would say that it is more pronounced in case of other causes of peritonitis. And UTI, you check whether burning micturition is there, if the patient had dysuria, if the patient had decreased urine output, which the patient didn't have, and also if the patient had any peritoneal dialysis catheter in situ, there are chances of more infection as well. So this is what how you can define spontaneous bacterial peritonitis. As you said, the most common presentation, especially in liver cirrhotic patients, would be fever with abdominal pain, and also the patient might have altered sensorium. One, it is because of the infection itself. Other, it is because of the trigger which can lead to hepatic encephalopathy. Right. So let's talk about fever. In liver patients, the baseline would be a hypothermic spectrum. They'll have lower body temperature compared to the other set of people. So if they have fever, it should be considered very significant. As in, some pathology is there which is severe enough to debilitate the patient, and you should be suspicious about this infection, and you should track and find out and effectively treat this patient. Second is abdominal pain. We all know that peritoneum has your visceral and parietal peritoneum. Visceral pain is mostly dull aching pain. Parietal is where the somatic innervations is there and where you get the sharp pain. And what is rebound tenderness? Basically, you're gradually pressing the abdomen. So when you're gradually pressing the abdomen, parietal peritoneum is not effectively getting stretched. They are slowly getting stretched. But when you immediately leave, what happens? Because of the pain, they're getting stretched very fast, and the pain is very severe. That's how you elicit that rebound tenderness. But what happens in ascites is that there is so much ascitic fluid, and when you press and you leave away your hand, there's a cushioning effect which would dampen the pain, because of which the pain is not very much elicited in such kind of individuals. That's one thing. The other one is encephalopathy and the altered sensorium that we talked about. It can be delirium, it can be because of septic encephalopathy, it can also be because of hepatic encaph as well. The most common organism that causes spontaneous bacterial peritonitis is
could be E. coli.
gram-negative spectra. Which one? Escherichia coli. The second most common is Klebsiella pneumonia, and followed by Enterococcus fecalis and all that. Right. Now, what is the pathophysiology involved? The pathophysiology in spontaneous bacterial peritonitis is mainly because of the translocation of the bacterial flora, which is very much, it should be safeguarded within the intestinal lumen. It should be safeguarded there. But what happens in cirrhotic patients? Because most of the patients who present to us are cirrhotic patients with spontaneous bacterial peritonitis. We are discussing about this spectrum of patients. What happens in cirrhotic patients is the intestinal motility is slightly on the lower side, because of which the transit time is increased. All right. And also we should realize that whenever a pathogen is there in the body, the first line of defense is macrophages within the intestinal lumen and everything. Macrophages, if they fail to deactivate the pathogen, the next line of defense would be complement mediated activation. After which there is polymorphoneutrophils that attack and finish them off. But here what happens is the complement mediated activation, there is decreased complement mediated activity, and also at the same time there is dysfunctional neutrophils in cirrhotic patients by default, because of which they can evade the immune checkpoints and immune system, right? So translocation, how does that happen? The set of bacteria, because of the leaky capillary walls, they tend to get into the lymphatic system, mediastinal lymph nodes, and also the bloodstream. Okay, as they get into the lymphatic channels, there is already an increased portal pressure which makes the lymphatic channels overwhelmed. The pathogen is inside within the lymphatic channels, and at some point or the other they rupture into the ascitic fluid, and it leads to the introduction of the pathogens within the ascitic fluid. This is how the issue happens, and it starts and it becomes full blown. And at the same time, we are also supposed to look at what are the most common risk factors associated with spontaneous bacterial peritonitis. The spontaneous bacterial peritonitis, the most common risk factors would include upper GI bleed. Patients who had prior history of upper GI bleed or presenting with upper GI bleed, who is malnourished. So one thing that we should be checking is if the patient is very much cachexic, malnourished. Then what else is there? What are the other risk factors?
Could be due to the severity of the cirrhosis. So if a child Turk score is if it's more than 9, or a serum bilirubin if it's more than 3. In this patient bilirubin was 4.
Okay.
So that's also another risk factor. Then
prior history of spontaneous bacterial peritonitis also makes them more predisposed towards spontaneous bacterial peritonitis.
Yes.
Right. I would want to know what would be the investigations that you would be doing in this patient, and with these investigations, how are you going to differentiate it from spontaneous bacterial peritonitis from secondary bacterial peritonitis?
So basically it's from the ascitic fluid. So in the ascitic fluid we check the protein levels. So if it's like usually if it's more than 1 gram per deciliter, the protein, it's usually due to the SBP. If it's less than 1 gram,
Okay.
It's usually due to a secondary bacterial peritonitis.
Okay.
Then what we check is usually the like neutrophil levels and all.
Neutrophil levels.
It will be more than like 4,000 will be multifold.
So the polymorphonuclear neutrophils, if they are more than 4,000. Here it is more than 250 is what we normally say. The cutoff is at 250. If it is more than 4,000, we should be thinking about other causes of peritonitis, right?
Then it's between like if it's transitive or exudative. That's also a differential factor, but it's not always specific. Then we check is the LDH and amylase level.
LDH amylase level.
So if LDH is high and if amylase is also high, both of these will contribute to a secondary bacterial peritonitis, not a spontaneous bacterial.
Glucose levels?
Glucose levels will be lower side, less than 50.
Less than 50. 50 is the cutoff. All right. Okay.
So,
and if at all you are finding bile in the ascitic fluid, that is more suggestive of some gallbladder perforation, which is lead to the peritonitis. And also, if say you have got a hemorrhagic tap, all right. So in that case, the red blood cells are there in the ascitic fluid right now. Is there any relation, or how can you estimate the actual amount of neutrophils when red blood cells are present? So if you get a hemorrhagic tap and if there are more than 250 red blood cells per microliter, for every 250 increase you should subtract 1 neutrophil from the original neutrophil count. Only then will you get the value of the exact neutrophil. All right. Yeah. And right. So also once we do the parasynthesis, what all are the tests that we are going to do with it? What else are the tests that we are going to do? Another thing that we forgot to mention was the gram staining. There's gram staining, there's blood culture, ascitic fluid culture that we sent as well. Yes. So gram staining, what would it reveal if it is spontaneous bacterial peritonitis? And
most probably it could be a gram-negative organism.
Gram-negative organism. It's going to be a monoflora. The single flora is isolated.
Yeah.
But if it is secondary, the intestinal, the entire gut flora will be there.
Yeah.
So it will be going to be a polyflora. A lot of
microorganisms
can be isolated. So that is one way of distinguishing them as well. So when you do the parasynthesis, one thing that we should make sure while taking the culture is that you insert the needle at the deepest pocket possible, and then you take in whatever for all the investigations possible. Eventually, if you're trying to test for the culture, then you should introduce a new needle, new syringe to the needle, because you don't want any contamination of the skin flora, which would be ideally removed with all the specimens that you collected earlier to the culture specimen. And then you'll have to, so what I'm saying is, after introduction of the needle, you collect samples for all the other tests, eventually introduce a new syringe, and then draw around 10 ml for the culture specimen. Culture is not always going to yield a growth, but it is required to, if it helps you guide the treatment. Say this patient, you drew the parasynthesis culture and every investigation possible, and you empirically started treating the patient. When would there be a condition where you need to do a re-parasynthesis?
Even after the 5 days of antibiotic treatment.
So 48 hours later, if the patient is not clinically improving, you'll have to check again. In that specimen, if the the neutrophil count, if it is less than, if it remains the same, or if it shows only a decrease of less than 25%, at this time you should consider other cause of infection as well. And then you should immediately do a CT abdomen and pelvis to contrast CT abdomen and pelvis to find out what the cause is. That is one way of dealing with such patients. Second, if there is increase, if there is decrease, if there is significant decreasing, treat it as spontaneous bacterial peritonitis itself. All right. Let's move on to the treatment. How are you going to treat this patient? Is there any scoring system for it as well?
There's actually a scoring system is coming with CLIF SOFA score. That's basically
there is a chronic liver failure SOFA score. What is different? How is it different from the SOFA? What all are the parameters involved in it?
We add bilirubin.
So it's a scoring system from 0 to 24. More than or equal to 7 is considered significant. All right. So we would go with hepatic encephalopathy. First thing is, if you start from head to toe, hepatic encephalopathy grades are there in the scoring system. When you go to CVS, you'd be checking about how many inotropes are required to maintain the MAP. Respiratory system, you check the PaO2 by FiO2 ratio. In the liver, you check for, as you rightly said, bilirubin and INR values. The kidney, you would check for creatinine values. This is how you estimate the CLIF SOFA score. And talk about the algorithm. There's a beautiful algorithm given. What antibiotics are you going to prefer in these people and why?
Yeah, so usually the algorithm is usually in empirical treatment. So as an empirical treatment of SBP, usually if it's indicated, usually in the patients with cirrhosis and ascites. So it's usually non-critical. We have to check whether the patient is non-critically ill or critically ill. So that is the initial thing. So in non-critically ill patients who have symptoms consistent with the SBP, or with patients with, or we have to check whether the patient is critically ill. If the patient is critically ill, we also have to we have to check the critical illness, the severity risk score. So that is usually the CLIF SOFA score. So if the CLIF SOFA score is more than or equal to 7.
So before, the one thing that they specify in the algorithm is that critically ill patients are those patients who are hypotensive. So if the patient is maintaining their BP, then ideally it is advised that the patient gets a paracentesis before administration of antibiotics. Alright. But if the patient is hypotensive, then immediately administer antibiotics and other supportive care before proceeding with paracentesis. Other asymptomatic patients, you can go ahead and proceed with paracentesis, and then the flowchart starts. Go ahead.
So we have to check whether the patient is having any critical illness. So the factors of critical illness is the CLF SOFA score more than or equal to 7, or the patient is in a septic shock. So then we have to check for the risk factors for any MDR gram-negative bacilli is there. So that's usually if the nosocomial SBP. It's after hospitalization if the patient developed an SBP. Or a non-colonization or previously colonized by an ESBL producing pathogen. Or a hospitalization or exposure to beta-lactam antibiotics within the prior
90 days.
90 days. And exposure to a geographical region with high rates of MDR.
In India, it is one geographical location where MDR is very high. So definitely that is by default there.
So if it's present, all these are critically, if the patient is critically ill and all these criteria are met, then we proceed with injection of carbapenems. So carbapenem is meropenem, 1 gram IV every 8 hours, or imipenem cilastatin combination 500 mg IV, which is given every 6 hours. And then we have to check for the MRSA also. If the patient is previously having history of MRSA or in the now new culture, if the patient is showing features of MRSA, then we have to add vancomycin also.
Vancomycin also.
So that is the initial treatment. If the patient is not showing any of these features, and if the patient is not showing any MRSA also, involvement also, then the antibiotics include ceftriaxone. So ceftriaxone 2 gram IV every 24 hours, and cefotaxime 2 gram IV every 8 hours. So that's the how the treatment goes. And then again we have to further monitor. It's usually the antibiotic course goes for about 5 days, and ertapenem is usually avoided. So carbapenem. So carbapenem usually ertapenem does not have much GI penetration. So that's why it's usually avoided.
Yeah. Carbapenem resistance is also an issue. If at all you have an isolate with carbapenem resistance, immediately infectious diseases should also be involved to find the suitable agent of choice for treating this patient. Right. What else do we give for supportive treatment? Albumin, is it indicated?
Yes, albumin is indicated if the patient has a low albumin levels. In our patient, the patient had an albumin of 3.2, but if the patient has a low albumin level, and then we have to supplement with like 25% albumin. It's usually IV dose. It should be given within the 6 hours of SBP.
Within 6 hours to prevent AKI.
So it's usually in a dosage of 1.5 gram per kg body weight, but maximum dose of 100 gram.
Maximum dose of 100
gram.
The patient is in fluid overload status. How much?
Usually we half the dose.
0.5 gram per kilogram body weight.
So it's 1/3 of the dose. So 0.5 gram per kilogram is the
kilogram body weight.
Yes.
We also try to avoid any beta blockers if at all
patient is hypotensive.
We tend to avoid that as well. And also, what is the problem with proton pump inhibitors?
Yeah. So patients using recurrent PPI, they have a high risk of SBP.
A high risk of
SBP.
SBP. Why though?
It's because of like decreased acid production, like
Decreased
defense
acid production, defense mechanism. is
mechanism.
impaired. And also the gastric motility is also
affected.
And also one thing is neutrophilic activation is also dampened with proton pump inhibitors. Again, immunity takes a hit with proton pump inhibitors, which would lead to that. So when this patient is being discharged, is there any particular antibiotic regimen that you follow and any advice that you're supposed to give?
So as part of prophylaxis, we can start on ciprofloxacin. So that's one of the like fluoroquinolones, or we can give trimethoprim, sulfamethoxazole. That's also combination can also be given as
ciprofloxacin. 500 mg can be continued until next visit, and accordingly we'll take the call of whether we should continue it again or not.
Yes.
And also we avoid proton pump inhibitors. Right. Anything else that we have to discuss? I guess it covers everything. Thank you.